All right, good morning or afternoon or whatever you're watching this. I first wanted to start by apologizing. I had no idea this was going to happen today. Well, I knew that this talk was, but there is some construction outside that I have absolutely no control over. And I wish there was something I can do about it, but it's going to go on. I talked to the people outside. It's going to go on for the next few hours and it is what it is. So if you're sound sensitive, maybe there's a way that we can like reduce the background noise of this video somehow. Before we put it up or something, that would be great, but we'll see. I'll be sure to talk to her about that. Anyway, so my name is Dr. Madison Oak. I am a vestibular physical therapist. I'm based out of the United States. I practice all throughout the state. So I practice in New York, New Jersey, Maryland, Virginia, and California. And then my practice is also located in Minnesota and Wisconsin through another vestibular provider. I have the vestibular rehabilitation therapy clinic, as well as something we call vestibular group fit, which is a vestibular based exercise program that is completely virtual online and is designed for people who are dizzy or have post-concussion or prolonged concussion syndrome, to return to exercise without the dizziness and to keep all symptoms under their threshold. So we're going to go ahead and talk all about the vestibular system, what dizziness is, and everything like that today through this slideshow. So I'm going to go ahead and share my screen, hopefully. Okay, so give me 1 second. I don't know how to do presenting mode. There we go. It's up here. I'm blocking it. There we go. Okay, so today we're here to talk about concussion and dizziness. And I'm sure if you're in this group, you know a lot about concussion, what happens with concussion, why it happens, when it happens, etc. So you're definitely in the right place for that. But we are going to talk about why we become dizzy after a concussion. So there is a lot of anatomy and physiology we're going to go through at first. It's kind of heavy, but stick with me here. And if you have any questions, I'm happy to answer them at the end. So I have no conflicts of interest. See, objectives. So we're going to talk about what is the vestibular system, what's the difference between dizziness and vertigo, why do concussions cause dizziness, what kinds of concussions occur, or what kinds of dizziness occur with concussion, and then how do we treat dizziness in concussion. So dizziness and vertigo are not the same things. So it's important to recognize that all vertigo is technically dizziness, but not all dizziness is vertigo. So dizziness is all of the words on the screen and more, anything from lightheaded, spinning, unsteady, floating, feeling like you have a hot air balloon in your head, are all things I've heard in the clinic. But vertigo is specifically the incorrect perception that you or the room around you is moving or spinning. So if you've ever been sitting or laying down and all of a sudden the room starts going by and it starts moving on you, sort of like you were in like a tilt-a-whirl machine, maybe at the theme park, and you're moving in circles, but you aren't actually moving, that's vertigo. So again, it's the incorrect perception that you or the room around you is moving, sliding, or spinning. It's important to differentiate between these two things because dizziness is, of course, not vertigo, and well, not all dizziness is vertigo, and being able to correctly and adequately describe your symptoms to your providers can help us really determine the best course of treatment for you and the best diagnosis to fit your symptoms. So again, all vertigo is dizziness, but not all dizziness is vertigo. These are the exact definitions here. I can read them to you again. Sensation, dizziness is sensation of imbalance, movement, or feeling off, lightheaded, heavy-headed, or other perception of discomfort, while vertigo is the incorrect perception that you or the room around you is moving, sliding, or spinning. So let's chat about the vestibular system, because usually when you feel dizzy, it is excuse me, it does tend to be because of the vestibular system. So the vestibular system is deep in your head. So if you can see here in this photo, this is your outer ear. This is the part that you can touch. It's the part that you see on the outside of your ear, all the way through your ear canal into your eardrum. So this right here, this pink part, is the eardrum. And the eardrum is what separates the outer ear from the middle ear. So everything that you can see where these three bones are, those are the tiny, tiny bones that produce vibrations when you hear. So you hear me talking to you right now. These three bones are vibrating and touching the inner ear here. So the middle ear is here and it goes down to this part that you can see. It sort of looks like a peninsula or something. That's your eustachian tube. Your eustachian tube is what manages the pressure in your inner and middle ear. So if you go scuba diving, or maybe you go up in a plane or your ears pop, that's your eustachian tube closing and then opening again. That popping is what creates the pressure volume relationship within your middle ear. Then on the right of that, this blue part here, this is your inner ear. So your inner ear consists of two portions. You have this snail looking thing, and that is your cochlea. And then you have your three semicircular canals and your otolith organs on the top side here, which is your vestibular system. And then attached to both of those things is the vestibular nerve and the cochlear nerve, forming your eighth cranial nerve called the vestibulocochlear nerve. And this part right here, that's what makes us dizzy. So again, we have the two portions. This is a different view of the same thing. So you have the cochlea on the right, just so we can get oriented again, and the vestibular system on the left. This photo is not perfect. So this pink part right here should be all the way connected. And quite frankly, I'm not sure why it's not. And then this red part is showing inside of the semicircular canals. And then this part right here should also be closed, but it's showing inside of that where your otoconia are. So you have two parts of the vestibular system in general, sort of like we talked about before with the blue picture. You have the semicircular canals and the otolith organs, and then the vestibulocochlear nerve, like we talked about before. And again, they're all on this left side of the vestibular system. Each part of the vestibular system has its own job. So these three, the semicircular canals right here, we're going to talk about them first. They are filled with fluid called endolymph, which resides in this pink part. And then the perilymph is in the bony labyrinth, which is this tan part. And that goes throughout the entire system. It helps conduct sound through your cochlea, and it helps keep your balance in the semicircular canals. Their job is to detect angular motion. There are three on each side, and the left one works with the right one in equal and opposite directions to determine where you are in space. Let's see if I can go to the next one. So when you spin, this is a photo of the sources down here, but when you spin, these canals, the fluid called the endolymph moves back and forth and hits this thing called the ampulla on the end. The ampulla moves and pushes over the hair cells, as you can see in the bottom, to tell you where you are in space, which helps move your eyes. So if you are spinning and spinning and spinning and spinning, your eyes need to move either with your head or against your head, depending on how you're moving. And the ampulla helps do that by stimulating the hair cells and talking to this nerve down here. Then you have the otolith organs. So the otolith organs are filled with otoconia, and they're right in here. And this is the part that when we talked about 2 slides before, where those little ear crystals were, there was an opening in the drawing with the gray stuff inside. That's just another drawing of the same thing. You have your utricle and your saccule. So those are 2 separate otolith organs. One is vertical and the other is horizontal, and they detect all linear motion. So the utricle goes forward and backwards, and the saccule does up and down. And the 2 organs on each side, again, so there's 4 total, and those are what are referred to often as your ear crystals. So they sit and they're attached to this jelly-like surface that respond to movement and gravitational changes in the linear plane. So imagine you're holding a plate, and that plate has jello on it, which hopefully you've seen before, but it's like a jelly-like kind of substance that moves back and forth with gravity usually, and it's kind of shaky. Then on top of that, imagine sesame seeds or maybe poppy seeds on top. And if you were to move back and forth, the sesame seeds would pull one way or the other, and determine where you are in space. So that pulling is what the otoconia are doing in the otolith organs. They are determining where you are in space depending on where your head is in gravity. So if you right now sitting up, tilt your head forward, the otoconia are both going to pull forward, and that sends a signal to your brain that says, okay, we're looking down. Same thing if you look up, maybe you go up in an elevator or down in an elevator, the same thing happens, but in the saccule instead of the utricle. Then we have the vestibulocochlear nerve. So I couldn't find a good picture of this, but it's basically just attached to the vestibular system on one way and the cochlea on the other side, and they go together. We did see it in that very first picture. But its job is to relay information about sound, acceleration, deceleration, and spatial awareness to your brain. So let's kind of talk a little bit about how your vestibular system receives and perceives information. So hopefully you can see me in this corner here. Basically, your head, put both of your hands on the side of your head. Now, your palm should be facing out, and you are going to kind of move your hands forward and backwards just a tiny bit. And that is the beat of kind of your vestibular system. It tells you you're looking forward all the time. When you look to the right, your right one should move up and your left one shuts down a little bit. And I say, okay, I'm looking to the right. And the same thing vice versa to the left. So all the time, your head movement stimulates or inhibits your vestibular system from moving. So that's the way that I like to think about this. Firing forward all the time. When you look to the right, this one fires more, this one fires less, and vice versa all day long. That helps with your vestibulo-ocular reflex as well, which is a really, really important thing to think about when we think about vestibular rehab, because that's the thing that we most train. So if you stick your thumb out in front of you, this is the next thing we're going to do together. Stare at your thumbnail or a crease on your thumb and move your head back and forth. Hopefully this doesn't make you dizzy, but if you move your head back and forth within about a 60-degree range, so 30 degrees each side, you don't need to go to the corner of your eyes by any means, your thumbnail should stay still. You should be able to have that stay still up to 240 beats per minute, which you can play on a metronome, or on Google, you can Google 240 beats per minute and some ticking should come up. And your brain is able to keep that thumbnail still. What happens when we get dizzy often is something called gaze instability. And that's when that thumbnail no longer is able to stay still when you're moving your head. So something we need to work on is being able to slowly relearn how to keep your thumbnail still when you're moving your head. It's all the job of your vestibular system and your vestibulo-ocular reflex to do so. Let's move on here. So let's talk about during a concussion, what kinds of dizziness you can get. This is the list of ones we're going to talk about today. It is not an exhaustive list, but it's the most common ones. We'll start from some of the most common, but one thing I do want to mention before we get started is that prolonged dizziness. I did find a study about this recently. I can try and send it out if anyone is interested. Let me know. That said, that vestibular migraine and VPPV are the most common causes of prolonged dizziness and vertigo post-concussion. So if you're having this dizziness that seems to come in attacks, and you might get some head pain with them, talking to a neurologist or a neuro-otologist is a really good idea. And if you have positional vertigo, so every time you lay down or get out of bed, you get this room spinning sensation, that's definitely also a good idea to look into a vestibular physical therapist who can help you with that. We'll talk about that first. So benign paroxysmal positional vertigo is a mechanical dysfunction in the otoconia, which again are those ear crystals we talked about in our brief anatomy and physiology lesson of the vestibular system, which causes them to slip into the semicircular canals. So again, if we think about that system, that curly Q kind of system. We have those three semicircular canals and your otoconia or otolith organs. The otoconia slip off from their jello-like substance and they go into this semicircular canal. And that causes the fluid to continue to move and hit that ampulla at the end that we quickly touched on. And that will keep your eyes moving even after you've stopped moving because of inertia. And that makes the room look like it's moving, sliding, or spinning. So this is true vertigo here. The endolymph, again, keeps moving, hits that ampulla, and that nystagmus or involuntary eye movement is triggered and therefore vertigo. This will last from between 15 to 60 seconds and won't happen again until you roll over or sit up or maybe look into a cabinet. It is benign, meaning it's not going to be something that kills you. However, it is very terrifying. Paroxysmal means that it's spontaneous. Positional, meaning it only happens when you change position, and vertigo, meaning that room spinning. The treatment for this is a cannula 3 positioning maneuver. It's actually unsafe to not have a cannula 3 positioning maneuver. Even though it is technically benign, it does increase your risk of falls and your risk for dizziness. And your vestibular system does have a hard time processing why you're moving, why it thinks you're moving all the time. So even if it is a scary thing to get a cannula 3 positioning maneuver, which we're not going to go into today, it is a good idea to get it done just so the BPPV goes away. It is one of those things where you can walk into the clinic with BPPV and walk out and hopefully never have it again. So it is worth going to get that treatment. The provider most qualified to treat this, at least in the US, is a physical therapist, specifically a vestibular physical therapist, and that's pretty typical throughout the entire world. Next, let's talk about labyrinthine concussion. So a labyrinthine concussion is trauma to your inner ear causing inner ear symptoms. So those inner ear dysfunction symptoms are dizziness, tinnitus, hearing loss, hyperacusis. But here today, we're here to talk about dizziness, of course. So during a concussion, we know that you have an injury to your brain, but we don't often think about the injury to our inner ear that can happen. And so that kind of inner ear disorder or dysfunction can happen because it got moved or traumatized during your concussion. Frequently, high frequency sensory neural hearing loss with or without vestibular symptoms following head trauma without a definite labyrinthine fracture. So a labyrinthine fracture means that bony part of your vestibular system, or the light tan part in that picture we've been seeing, is fractured. It does not need to be fractured. It can just be traumatized otherwise. There is some evidence for sound therapy. It can take up to or over a year to do that, but I am not a sound therapy expert, so that's something that you can look into though for yourself. And then vestibular rehabilitation therapy for the trauma to your vestibular system can be really helpful. Some of those exercises can be things like keeping your thumb still while you move, or exercising in a subsymptomatic threshold. Trauma-related unilateral vestibular hypofunction is what we'll do next. There's a citation there just in case you can't see it. I don't know if you guys can see me on this little square on the corner or not. I just want to make sure you can see the whole screen. So trauma-related unilateral hypofunction. So we talked about both of your ears firing, saying, I'm looking forward at all times. When you turn to the right, your right one fires more, your left one fires less, and vice versa. When you turn to the left one fires more, the right one fires less. And all day long that happens. So if you have a unilateral hypofunction, that means at all times, one is firing less than the other. So even when you're looking straight, this right one fires left and less, and this left one fires more in this case. Okay, so this is a right unilateral hypofunction because this is my right side. This will decrease gaze stability and increases imbalance. You might have difficulty walking, especially in crowded or uneven environments. You could have blurry vision, nausea and vomiting, and just general dizziness, and maybe even some vertigo at first. So this is because your brain now thinks in this position that you're spinning to the left all the time, even when you're not. Or if your right one's firing more, your left one has the dysfunction, then your brain thinks you're looking to the right all the time, even though you're not. That's really confusing for your brain, but it can be relearned that this is your new normal. So we're typically not very good at regrowing nerves just as human beings in general. However, we can relearn what our new normal is. So if your new normal is unilateral vestibular hypofunction, your brain says, okay, this is actually us looking forward. And if we look to the right and the left one fires a little bit less, that means, okay, we're looking to the right and vice versa. So gaze stability exercises, so that's keeping one thing in your vision still while you move your head all around. Balance exercises, single leg stance, standing tandem, which is one foot right in front of the other, standing on uneven surfaces, and then practicing new tasks on those uneven surfaces. So let's say you stand on your pillow with your feet together, and then let's practice like tossing a ball or passing with someone or reading a book or cooking or something on that uneven surface to increase your balance overall. General exercise, as we know, is really, really important for concussion and prolonged concussion, and then anxiety reduction. So it can be really scary to move when you feel really dizzy, but practicing this in a safe environment, especially with vestibular rehab, can be incredibly helpful. All right, next we are talking about trauma-related vestibular migraine. So this is one of the things that I said at the very beginning is one of the most common causes of prolonged dizziness that is not just prolonged concussion syndrome. So you do have to differentiate what's prolonged concussion and what's vestibular migraine, but it is important to know about this diagnosis. So post-traumatic migraine is head pain and true migraine pain, which is different than just like a pressure or tension headache. It is a neurological dysfunction where your trigeminal nerves, that's cranial nerve 5, it looks like this in your face. You have 3 branches. And that has something called a cortical spreading depression, which is a series of really high electrical activity followed by a drop in really low electrical activity that causes a migraine. Migraine is a disease. It's not just a random headache. It's more than just a headache. And we know that because we're going to talk about vestibular migraine. So vestibular migraine has the same mechanism at first as a classic painful migraine. However, it also causes dizziness, vertigo, imbalance, and more. It can present with head pain or without head pain, which is the confusing part about it because it can just seem like a constant flare of your symptoms. That's why it's so important to talk to your neurologist or neurotologist about this if you think it might be happening to you. If you have migraine or vestibular migraine, the best form of treatment is a holistic group of treatments rather than just one thing. Just one pill or just one exercise, just one supplement isn't going to be the thing that treats all of migraine. It's just like concussion. You need a really big group of things and probably a team of doctors to help you. But vestibular rehabilitation therapy, exercise, medication, cognitive behavioral therapy, acceptance and commitment therapy to reduce anxiety and depression around that, and lifestyle changes will all be really helpful. Lifestyle changes are things like dietary changes, making sure you're hydrated, scheduling in relaxation and meditation, things like that. Otolith damage is next. So in this picture, we've been kind of referencing all day. We have our otolith organs. They're this part right here. And inside that otolith organ, I guess I should have showed you this picture earlier. We have your otoconia. These are the ear crystals. These are the things that fall into the semicircular canals during BPPV. Then you have your jelly layer. Then you have the hair cells or the macula, and then your vestibular nerve. So damage to the organ, which is your linear acceleration detector, can cause a pulling or tilting sensation. So again, because these are linear motion detectors, we know that you might be having trouble if you're feeling like you're being pulled forward or pulled to the side rather than rocking or feeling like you're moving at an angular acceleration. So cognitive behavioral therapy, always really helpful. Compensation techniques like using a cane or always wearing flat shoes, being sure that your glasses prescription, is correct. Any of those things can help. as well as, again, my favorite thing, vestibular rehab therapy. So one of my favorite exercises for this is if you feel like you're being pulled to one side and then overcompensating to the other, you might be leaning and not knowing you're leaning, which can really affect your balance. So one thing that I really like to do is find a mirror and then line up a piece of blue tape down the center of the mirror in a perfectly straight line. Then you're going to line your body up so you can see your eyes on either side. Your nose should be lined up, your belly button, your pubic bone, and then your feet should be on either side. Then you'll keep your feet still, move all around, kind of go like this, left, right, forward, backwards, maybe in a circle if you're getting really crazy, and then stop and try to reorient yourself to center. Open your eyes and see if you are back where you started. If you're not back where you started, take note of that. Take note of your internal body position and say, okay, I actually need to be here. I need to be shifted a little bit to be straight, and then do it again. Over and over again, your body will relearn how to go back to that center at baseline. Traumatic secondary endolymphatic hydrops. So endolymphatic hydrops is a pressure problem within your inner ear. So this system right here, let's talk about the pink part. You can see kind of the pink part on the very right. There are two holes and then this third triangle looking hole. These two holes are what have the endolymph, and then there's perilymph in the triangular looking one. What happens with endolymphatic hydrops is there's, not pictured here, an endolymphatic sac that kind of sticks out this way. It's filled with more endolymph, or that pink part. And the pressure dysregulation caused in the inner ear's endolymph, it will cause it to swell in the membranous labyrinth, and it will cause dizziness, lightheadedness, imbalance, and increase the potential for you to have BPPV, which again is where these otoconia fall out of the otolith organ into the semicircular canals, causing vertigo. But basically this pressure dysregulation, the endolymph presses into the perilymph, it expands into that endolymphatic sac, it can press on that vestibular nerve, and that secondary endolymphatic hydrops is caused because of trauma. Typically within 1 to 2 years, it will go away by itself. However, it can be managed before that with diet and lifestyle changes. So you want to do low sodium, low sugar diet, make sure you're staying really hydrated. There's potential need for a diuretic, but of course that's between you and your doctor to decide, because that will help maintain your whole body's fluid balances equally. And then vestibular rehab therapy, of course, if you're feeling like you need to increase your balance or improve your gaze stability through exercises. There's also some evidence for primary endolymphatic hydrops, which is a little bit different than this, but same mechanism. That high intensity exercise helps. So you could probably extrapolate that to secondary endolymphatic hydrops as well. That could be helpful as well. A perilymph fistula is what we'll talk about next. And that is a hole or tear in your inner ear in the oval or round windows. So those oval and round windows are here and here. And those are the parts where your ear bones attached to send those vibrations towards, to talk to your cochlea to be able to hear. Basically, there will be a tear in that space or opening it extra called a perilymph fistula, and it can cause dizziness, imbalance, ear fullness. So feeling like your ear is just like full of fluid, even though the doctor will look in there and be like, no fluid. There'll be fluctuating hearing loss, motion intolerance, and it will be worse with elevation changes because of the pressure volume issue. If it doesn't heal independently, you should talk to your doctor about the time in which that healing should occur. You can get a surgical repair, and then vestibular rehab as always for any dizziness, imbalance, or motion intolerance. Autonomic dysfunction is a really, really big one. And post-concussion, a lot of people can develop POTS, so post-orthostatic tachycardia syndrome. And if you believe you have POTS, it's really important to get that checked out by your doctor as well, just as everything else. But autonomic dysfunction is when your autonomic nervous system. So you have two parts. You have the sympathetic and parasympathetic system. Your sympathetic system is your fight or flight system, and your parasympathetic system is your rest and digest system. So those two things are always moving back and forth depending on what you need to be doing. So let's say there's a bear chasing you, you're going to go into sympathetic, you're going to run from the bear. If you want to relax and sit on the couch, your body goes to parasympathetic so that you can rest and digest. So concussions often impact the parasympathetic nervous system, and the system cannot properly regulate your heart rate, which leads to heart rate variability that's not stable. So your heart rate should be variable throughout your day. If you're sitting down, it should be lower than if you're standing or running or jogging or lifting weights or whatever you're doing. There should be some variability. But what happens is that system can no longer regulate it at all, and your heart rate will spontaneously shoot up. And this can look like anxiety. It can look like heart racing. It can look like a lot of different things. So you might have decreased blood pressure, increased or dysregulated heart rate, which sometimes is tachycardic and can cause dizziness. It causes a lot of anxiety, and it can cause a lot of lightheadedness. With this, vestibular rehab is important here, but that won't treat a lot of the dizziness that's at fault for the autonomic dysfunction, because it can be a cardiac issue instead. So instead, keeping your lifestyle and dietary changes in check. So if you need to make sure you're staying really hydrated, eating a really well-rounded diet, making sure you're sleeping enough, etc., that's all really, really important, but also progressive exercise tolerance. So you want to be able to at least walk across the room without your heart rate just going through the roof. So starting with a couple steps and then sitting down, starting just sitting up in your chair versus lying down, doing deep breathing, doing it over and over and over again until your brain relearns how to regulate your autonomic system. Your autonomic system is, again, automatic. However, we can use our brain to try and retrain that function. There's a lot more to it than we could have time to talk about today. But if you feel like your heart rate is dysregulating, it's really, really important to talk to your physical therapist about this and your doctors. So anxiety and psychosocial changes. The estimated prevalence of anxiety disorders in PCS ranges from 18 to 60%. So that's a large amount of people. That's almost most amount of people, especially if it's over 50%. And anxiety and dizziness are really connected. It's scary to be dizzy. No one likes to be anxious, but the more dizzy you become, the more anxious you become. And the more anxious you become, the dizzier you become. And it's just this cycle that feeds on each other over and over and over again. And that can be really frustrating because breaking that cycle can feel impossible. However, it is possible to break. And it's actually sometimes easier to break the anxiety part than it is to break the dizziness part. The two places where anxiety and dizziness synapse in your brainstem are super, super close. So not only are those two things scary, therefore causing anxiety, but it's also they're physically close together, which can cause neuroplasticity for them to start to wire together. So in neuroplasticity, we say neurons that fire together, wire together. So things that fire at the same time, saying, okay, I'm dizzy now. Oh my gosh, I'm so nervous. I'm scared. I'm going to be dizzy forever. Those two things are going to start to wire together. So cognitive therapy is really great to say, okay, I'm dizzy. Oh my gosh, I feel really anxious. Okay, let's replace that thought and say, actually, this is okay. I've been here before. I'm going to get through it again. And working with a cognitive behavioral therapist, which I am not, I just send a lot of my patients to them. And I think what they do is excellent, can be really helpful. Pharmaceutical medications like SSRIs can really help. And then, of course, exercise, which reduces anxiety and depression, and then vestibular rehab therapy. So you have a place to move that feels safe. I want to quickly touch on something called persistent postural perceptual dizziness, which is more common in those who have a history of anxiety and depression. Approximately 60% have a history of an anxiety disorder with 3PD. And 3PD is the chronic feeling of dizziness that is based upon you feeling dizzy, like you have non-spinning vertigo. So you'll feel like an internal rocking or swaying, which will feel worse in visually intense situations, or if you're upright or if you're moving. So you won't feel better moving, you'll feel worse moving at first, especially, and it will be present every day or most days, more than half of the days for 90 days at least. But you do have to have a secondary diagnosis. In this case, it's most likely concussion, and a history of concussion can lead to 3PD. That is treated. The gold standard of treatment is returning to a functional schedule throughout your day, exercising, having a support group, and sometimes something like an SSRI or an SNRI. Okay, visual motion sensitivity. Visual vertigo, or VMS, is when movement by you or the environment that you're sensitive to. I guess I didn't put that you're sensitive to at the end of that sentence. Sorry about that. But basically, you are moving or the environment around you is moving, which creates optic flow. So things around you flowing across your optic system, your eyes, basically. So let's say you're walking through a forest and you see all the trees passing you by, or you're driving past a field and the field is passing you by. You're watching a movie on a big screen. Any of those things cause optic flow, and that can be really difficult for you to watch. So there's a mismatch in the input from your eyes, ears, and proprioceptive systems. So all three are supposed to tell you where you are in space at all times, and they're supposed to check in with your vestibular system to say which one's telling the truth. So if you're standing on an uneven surface with your eyes closed, that is taking away your proprioception, it's taking away your vision, and you are completely reliant on your vestibular system. However, if you're standing on the floor and your eyes are open and you're watching a train go by, all three systems are working at the same time and your feet are flat. Okay, so let's listen to our feet. They're flat. It's all good. I'm not moving. Let's listen to our eyes. Things in front of me are moving because I'm watching a train go by. Your vestibular system picks up on, are you accelerating? Yes or no. So if you're standing still, your vestibular system knows I'm standing still, I'm upright, I know where I am in space. But then if something goes by you and your vestibular system isn't working at 100% capacity, then your whole body starts to rely on your eyes, and all of a sudden your eyes are your truth tellers. So although you might not be moving, your brain is interpreting that I am moving because there's a train going by me, it's blurry, it's moving, my eyes are moving, I also must be moving, even though that's not true. So optokinetic training and then vestibular rehab therapy, which it should be a part of your VRT, retrains your brain to understand that just because things around me are moving doesn't mean I'm moving. So you're able to increase the amount of optic flow without you feeling nauseous, motion sick, etc. Exercise also helps with this, and of course, cognitive behavioral therapy. So treating dizziness in concussion. Subsymptom threshold is really important for exercise. So doing the Buffalo treadmill test and Buffalo treadmill protocol can be great. That is what I use in the clinic. I actually treat via telehealth, but I ask people to either go to their gym downstairs in their building, or if they have a treadmill at home, use a family friend, something like that. We always find a way to do this. I do think it's important. So you can find where your symptom threshold is. It uses two different symptom thresholds, and every minute on the minute you raise either the speed or the incline or the resistance, depending on if you're using a bike or treadmill. If you haven't done this already, ask you to do it with your provider if possible, because even if you're starting at the lowest possible level, sub-symptom threshold exercise is really important because rest is not best when it comes to concussion. We know this, there's so much research on it. Resting 2 to 3 days maximum before you return to light activity is perfect. So you should be evaluated by a professional within 4 days. That will help reduce long-term effects of your concussion and will have best treatment outcomes. Vestibular exercises specialized to you along with your sub-symptom threshold exercise program is ideal. And then relaxation and breathing exercises for those autonomic and psychological responses that you feel like, oh my gosh, I shouldn't be so nervous about this, but maybe I am, to help regulate your heart rate. There's a lot that goes into this that we don't have time for today, but These are the basics. It's really important, again, to move and to exercise. Don't go above your symptom threshold. Your symptoms shouldn't last more than 5 minutes if you're doing vestibular exercises, and all exercises should be tailored to you. Vestibular group fit, I want to touch on this one more time, is great for this. So I would recommend first working one-on-one with a physical therapist, but once either your insurance runs out or you're feeling like you have time to go on your own, vestibular group fit is the only exercise program designed for people with dizziness and vestibular disorders to help return to exercise. So all exercises can be performed in your home at a sub-symptom threshold. All exercises are completely safe for you. There's some cardio, there's some strength, and all exercise classes, of course, because they can be done from your home, are safe. You can always message me. You have 24/7 access to me for all questions you might have about your exercises at home. And you can do them live in class and ask during class as well. And I will always reply to you. So 3 times a week live workouts, 3 times a week on your own workouts, a monthly balance challenge to improve that, premium content modules every other week. So things like managing fatigue, treating visual vertigo, how to cook without getting dizzy, how to handle the holidays, etc. There's so much content in there. And then there's also a support group. And I know a lot of support groups in concussion and in vestibular can kind of be frustrating and feel like a chronic downer. However, in this group, we avoid toxic positivity, but we do try to focus on what we can do rather than what we can do. So every week we have a theme, and then we check in and see if we've met our goals at the end of the week. Almost, maybe, yes, no. And we talk a lot about what we can do and focus on that rather than what we cannot do. Of course, if there are questions about, hey, how do I do this? How do I make this better? That is always an option to ask. But I do want to make it clear that focusing on what you can do, no matter what your vestibular diagnosis is so, so important. Okay, thank you so much for listening today. I was so excited to be able to give this talk. If you have any other questions for me, you can always email me. I believe my contact information is on that page, but you can find me everywhere on the internet at The Vertigo Doctor. So it's thevertigodoctor.com, The Vertigo Doctor on Facebook, The Vertigo Doctor on Instagram. It's always all one word. The only one that's different is Twitter, and it's The Vertigo Doc because it was too many words for their handle. Here are my sources. If you have any questions about anything, I can go ahead and send you anything you need, if there are any other questions for the day. All right. Thank you so much for listening. I'm so excited. I will see you next time.